What is the leading cause of deaths for trauma in pediatrics, Dr. Murto?
Well, I mean, it's still, hemorrhagic death within, the first, 6 hours. It's very similar when you look at some observational data that came out of the MATIC trial group, and you sort of see a similar hemorrhagic death rate compared to adults. The only difference is that by 24 hours, you start to see, 40% of the deaths are due to traumatic brain injury. And so perhaps there's a little more traumatic brain injury that we see in kids. And perhaps that is part of the reason why the death rates that we see still remain persistently higher in pediatrics compared to adult.
Is that just because there are differences in anatomy and physiology?
Yeah, that's a big one. Bigger head in proportion to the rest of their body. Maybe their neck musculature isn't as able to stabilize it. So when you're getting into sort of, significant forces that are generated in accidents, maybe that head is not controlled as well. The other things that we're seeing is that there's a really robust cardiovascular response to kids. And such that they can be in sort of a, class 2, class 3 hemorrhage and still have, reasonable vital signs. And you may be lulled a little bit before they sort of drop off the edge, the cliff, so to speak, and get into trouble where maybe it's a little more anticipated in the adult world. And I would also say that there's a size issue. So, when I'm doing talks about, 4 or 5 kilogram baby that loses half their blood volume, it's like it's equivalent to half a can of soda when you look at it. And so it's deceiving. Babies can bleed intracranially because their suture lines in their skull have not sealed yet. And so they can lose a lot of blood intracranially. Again, you don't see it. Their scalps are very vascular, and so you can lose a lot of blood there as well. So there's a lot of size, anatomy, and physiology issues that perhaps put a child at a disadvantage when it comes to recognizing significant hemorrhage.
That's interesting. And you said they can compensate so well with their heart rates, then they crash typically. But in your experience, is there any ways we can tell like they're at high risk of decompensating quickly?
Yeah. So, you'll hear about the shock index, and the shock index is, your heart rate divided by your systolic blood pressure. And in the adult world, I think once you have a shock index that's over 0.9, that starts to tell you that there's some sort of compensation that's going on. We need to be concerned about it. So what they've done is they've created something called SIPA, which is the shock index pediatric adjusted. And so that's taking into consideration normal heart rates in younger kids, middle-aged kids, and then adolescents. And so when you look at that same relationship of the heart rate divided by systolic blood pressure, you have a SIPA in kids up to about 6 years of age of being 1.2 is a threshold, and then down to 1, and then 0.9 once you hit the adolescent age group. So that's the first, suggestion that there's something untoward that you perhaps should be worried about blood loss. If you look at trauma in particularly, and the reason why I say this is that I think similar to the adult world, when we're looking at massive hemorrhage, it's not only about trauma, which accounts for about 50% of blood loss, but the other 50% is medical bleeding and then OR bleeding.
I used to be at Sunnybrook, and, we got a bad trauma, and I was standing there talking to the medics at the back, all the surgeons are at the front with the blood, and we're having a chat. And I'm like, oh, this patient is so hemostatically deranged. Like, we can't possibly save somebody when they get to this point of no return. We have to give the TXA, we have to keep them warm. And they're like, Jeannie, you got to start like right at the roadside. You have to start at the St. Elsewhere Hospital that sort of packages the patient up and brings them in. You're going to have to start early if you want better outcomes. It was so great. It's just like one of the orange helicopter guys, and it's like, wow. Yeah. So we developed a provincial massive hemorrhage protocol to cover the entire patient's journey, not just when they arrive at the hospital, and try and repair them from the point of no return. Let's start focusing on the patient. And so one of the things that came up is like, okay, the TXA has to be given faster and earlier. And over the last 10 years, we slowly tried to alter the TXA to get to the point that we're now getting 90% of the patients get their TXA, probably about 75% of the patients get it within the first hour. Well, we want 100% getting it and within that first hour. So we're good, but we're not perfect. And there's no way we can get to 100% in the first hour unless you guys are on the same team with us and you help us achieve that quality metric of 60 minutes to your TXA.
Because the sentiment, correct me if I'm wrong on all this, like I've heard this a bunch in my career, TXA is big in the military, but the reason why it was kind of held up, there wasn't a lot of pre-hospital research to substantiate it was effective. But then that changed. And like you said, that we have to get it in as soon as possible. Because what happens if I delay TXA for 45 minutes to an hour? What's the implication?
Yeah, so every 15-minute delay to getting your TXA reduces its benefit by 10%. And so basically, right, it's just ticking. Like the benefit is going down, down, down. And people have been able to show by giving it in the pre-hospital phase, you move it up by about 30 minutes. That's a big difference. Like that's like changing lives. And the two of the big pre-hospital trials, merged their data together between the STAMP trial and the ROC TXA trial. And if you put that large number of patients together, they were able to show it's completely safe and it saved lives. And honestly, it's cheap. Like the cost of it, I don't know, somewhere around $10 a patient. So where else are you going to find a treatment that's as cheap as that and as effective as that? We can't, afford not to do this for every single trauma patient coming in.
I'm just trying to think. You definitely know better that I don't know any other medication. If you decrease the time of its administration by 10 minutes, it reduces its effectiveness by 15 minutes. Like that's massive.
Yeah.
Like a massive decrease in its effectiveness. Yeah. And I'm just thinking, especially like in rural areas in Kingston, if you have a motor vehicle collision on the outskirts and you have like a half an hour transport and you didn't have TXA, you can see the window of opportunities getting terrible.
You can't possibly have a trauma center in every small rural community. So that's just never going to be possible. And so we're going to have to figure out how to do more in the pre-hospital phase. And starting with TXA is like a really good choice.
So why is it so beneficial? Like, what does it do?
Yeah. So when you're in a trauma, you can imagine your blood vessels have a lining, and it's called a glycocalyx. So it looks like almost like hair on the inside of your blood vessels at a microscopic level. Everybody thinks of their endothelium as this like flat surface, because if you look at your drawings in medical school and, your science undergrad, it's just like this flat thing on the inside. And it's not flat. It's like hairy thing. When you go into shock, you're frightened, your epinephrine's up, the glycocalyx is disrupted. And that disruption triggers this thing called acute traumatic coagulopathy. And when that happens, the glycocalyx exposes, first it releases that thing getting disrupted. It's great. It gives the patient about a liter bolus of fluid from the glycocalyx. So like, that's amazing. So you're not the only ones that are, resuscitating these patients. Patients' own physiology is also resuscitating them. It does a bad thing in the sense of it releases a little bit of natural heparins from the glycocalyx. Obviously, if you're in shock from an infection, maybe that's an okay thing. But if you're got a gunshot wound, maybe having your endogenous heparin bumped up, that's not so good, but that's what happens. A molecule called thrombomodulin gets upregulated. It plays with thrombin, its best friend. And it's that combo activates your protein C, which at the end of the day releases TPA, which is what we thrombolyze people with a stroke. Or if you have a snake bite, that's what happens with a snake bite. And of course, when you get a snake bite, you start bleeding. And so basically, it defibrinates you and reduces your fibrinogen and your fibrin clots. So TXA intercepts that terrible chain of reaction that's happening. That's great for sepsis, but it's not so great for bleeding. We're not exactly sure how it's saving lives because it's not from reducing transfusions, doing something that we don't completely understand. And so there's a little bit of magic in the TXA because it's not changing the number of red blood cells that they get. So how it's changing your outcome isn't completely from the bleeding. One of the really important things about why it's so important to give it pre-hospital is we can see in the studies where they give it pre-hospital, when you arrive, your thrombolytic markers are much more controlled and much better. And so you're bringing us a patient whose acute traumatic coagulopathy isn't so bad. And that makes it easier for us to manage them. Because I think they're going to bleed a little bit less. Their numbers are going to look better. We're not going to have to give them so many transfusions. You're just bringing us a patient that's going to be easier to manage. And that's been shown in really good studies where, I don't know how they did this, but they managed to do a blood test, give the TXA, and then when they arrived, do another blood test to show how much it improves the coagulation if you give it pre-hospital.
So if you find this work valuable, the simplest way is to support the podcast by subscribing and sharing it with someone who would benefit. And I want to recognize and acknowledge Casper, which is the Canadian Ambulance Service, Paramedicine, and EMS Research Repository. It's a free, open access platform making paramedicine and EMS research more visible, usable, accessible, and operational across Canada. So a huge credit goes out to Dr. Alan Batt and the team for leading the work and advancing open science in EMS. This podcast is for educational and informational purposes only. It is not medical advice, does not establish a standard of care, and must not be used to diagnose, treat, or manage any medical condition or emergency. The content discussed reflects general principles that may not apply to every situation, system, or patient. Clinical practice varies by region, service, and jurisdiction. Always follow your local medical directives, clinical guidelines, protocols, and the instruction of your medical oversight or base hospital physician. The host, guests, and producers make no representation, guarantees, or warranties regarding the accuracy, applicability, or completeness of the information shared. The views expressed are those of the individuals and do not necessarily reflect those of their employer, regulatory bodies, or medical oversight authorities. By listening, you acknowledge that the host and guests assume no responsibility or liability for any actions taken or not taken based on the content of this podcast. This material is intended solely as a supplemental educational tools to support ongoing professional development, not a substitute for accredited training, certification, or authorized clinical guidelines.